Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Okay, thanks for joining us, everybody, for this learning collaborative as part of the Pharmacist Physician Collaboration. Today, we are going to be learning from Dr. Corey Grant and myself about the lessons learned from the Physician Pharmacist Collaboration from our AHRQ-funded project in the Tennessee Heart Health Network. So my name is Ashley Ellis. If you're not familiar with me, I am the Assistant Dean for Strategic Partnerships and Innovation in the College of Pharmacy and the Director for Practice Innovation in the Tennessee Population Health Consortium. And I'll let Dr. Grant introduce herself.
Hi, so I'm Corey Grant. I used to be at the University of Tennessee working with this lovely group of people, but I recently moved over to the University of Houston. So I'm currently a research associate professor in the population health and sociology, population health with a primary appointment in sociology at the University of Houston. But I worked with Ashley and with our Dr. Ellis and with Gladys on this project for several years under the AHRQ funding before I left. And I'm very excited to be able to present some of the findings from the study to you today. This is hopefully will be more of an interactive presentation, but we're going to talk about what we learned from the Physician Pharmacist Collaboration.
Okay, so on this slide, we talked about when we initially began with our Tennessee Heart Health interventions and our AHRQ funding, we really wanted to focus on workforce development. So that included deploying community health workers, or as we refer to them as health coaches, across the state of Tennessee in primary care settings. So we really view health coaches as community health workers with training, some extra training around chronic conditions and around motivational interviewing. So we performed some of that. We also had motivational heart health messages. Those were text messages that clinics could select into. And then we had a pharmacist-physician collaboration. And that increased the delivery of population health services by clinical pharmacists. And that could be in a fee-for-service model, and a value-based model, in an academic partnership. So you can see the breakdown there of what practices chose. And some practices did choose more than one intervention.
Now, I'm going to start with a little bit of the background about these clinical pharmacists. So clinical pharmacists are located within primary care clinics or within a group of clinics. So some may go from work in a number of different clinics. They focus a lot on chronic disease interventions for hypertension and diabetes. And also lifestyle interventions. We've seen in the literature very favorable results on chronic disease outcomes with the inclusion of a pharmacist in primary care. And then there was a study that published a survey that they did with primary care providers. These were physicians. One reason to consider the co-location of a pharmacist in primary care is because of the shortages in primary care health professionals in Tennessee. So in 2020, about 90% of Tennessee counties were designated primary care professional shortage areas. And then to talk about the study, there was a study of primary care providers, just over almost 120 physicians completed the survey, and this was a 40% response rate. So that's pretty good, especially with physicians. Most had worked with a pharmacist for at least 2 years. 87% agreed that clinical pharmacists reduced their workload. And they did that by working directly with patients and non-provider staff, improving overall medication use, helping patients meet health goals and their quality measures, and just overall helping them to effectively manage their patient panels. And 91% of these physicians were extremely satisfied with the services that were provided by the clinical pharmacists. And the authors of this research suggested that this information could be used to justify the expansion of clinical pharmacy into primary care, and that it really helps with 4 specific drivers of burnout: workload and job demands, efficiency and resources. It helps provide meaning back into the work, and it helps with social support and community at work. And so we're going to talk today about a study that we did. We used a qualitative method called photovoice, and we did this study with pharmacists who had been participating in the Tennessee Heart Health Network intervention that Dr. Ellis mentioned at the beginning of the presentation. So photovoice is a qualitative research method that uses photographs and journaling to help shed light on the experiences that the people who are participating in the study have related to the objectives, the informational goals of the study. It's a collective storytelling process because we bring everyone back together in one sort of focus group type environment, and everyone talks about their pictures and what they mean, and then everybody discusses them. And the photos and context inspire action and drive for change. So this study we did describes the lived experiences of the clinical pharmacists who were managing chronic diseases in these primary care practices. And just to briefly touch on the methods, the study was approved by the University of Tennessee IRB. To recruit the pharmacists, we emailed the pharmacists that were participating in the Tennessee Heart Health Network. We provided some education about photovoice and then obtained verbal consent. The data collection process takes about 2 weeks. So for 2 weeks, we asked the pharmacists to take pictures of things that represented their experiences with the objectives of the study. We'll talk about that in a minute. So they took photographs and they sort of journaled what the photograph meant to them. There were 6 participants, 6 pharmacists that participated in the data collection process. There were 4 who participated in the focus group. And then we did a qualitative analysis to identify themes that really resonated with the majority of the pharmacists that were participating. And these are the study objectives. First, we wanted to know how the intervention influenced their collaboration with other healthcare professionals in the primary care practices, what the specific challenges or barriers were to implementing the intervention, the successes or positive outcomes that they experienced, both for the patients and for the physicians and staff and the practices, and then what changes in patient care outcomes could be attributed to this intervention, and how the collaboration affected their ability to provide patient-centered care, and any specific moments or interactions that they believe best represent the impact of the pharmacist-physician collaboration and intervention on the practice. And now Dr. Ellis is going to talk a little bit about what we heard.
So, as we go through these next few slides, this is going to include the actual photos that were provided to us by the participating pharmacists. And these are pharmacists that did participate with us in the Tennessee Heart Health Network. And they're describing kind of a day in the life of their practice and some of their feelings that they have, some of their interactions with patients and things like that. That was kind of how it was described to them. So in this picture here, you can see an open door in an office type setting. Like it kind of looks like a medical office. And so underneath it, you can see the kind of quote that was given to us by the participant. And it says, "I have an open door policy to help with warm handoffs or patient encounters and real-time drug information questions." And so after a participant would share the photo or share their experience, then the other pharmacists who are participating would kind of give their information or their reactions to the photo as well. So you can kind of see those over there. So one of the barriers that other pharmacists that resonated with was physical space for the pharmacists in primary care. You've got to be innovative. You've got to think outside the box. You've got to create space. And this is definitely true. I know that even for myself, I said I've had many an office in a closet. So you kind of have to figure out what the culture is where you work and see patients where you can make space. I was told my office was put as close to the precepting room as possible so that it could be easily accessible for encounters with patients and questions in general. Or being positioned in the center of the clinic, and that allows for a drive-by with providers. And then we have, it takes a certain type to be successful as a pharmacist in primary care. You have to build relationships with providers and everybody in the office until you get to the point where they can't work without you. And so because this is something that's not necessarily seen in every office, the pharmacists were expressing working up to the point where you were really integrated into the workflow. And that's what was expressed and discussed with this particular picture. Do you have anything to add there, Corey?
No, just that like a lot of these themes, we saw really a lot of consensus. As you can see, most of these quotes came from different participants. So just as we go through this, keep in mind that these are really the themes that resonated with most of the participants.
Okay, this one is another kind of fun type picture that you might not think immediately, but this is, it looks like a newer type tree, right, that's planted in someone's yard. So it says there's a lot to be said about relationships you get to build with providers, support staff, and patients when you bring medication expertise into a practice. What starts off as collaborations on patient safety initiatives has been growing into something bigger and developing stronger roots. So that's the correlation between that picture and the thought in that person's mind. So pharmacy right now, these are some of the other quotes that the other pharmacists in the group responded to. Pharmacy right now is included as a line item in our practice manager and business meetings, and that gives us a platform to explain what we're doing and what resources we need to improve processes and policies. Another pharmacist said, I was the first pharmacist hired in an outpatient setting, and now it's a full team with a meeting schedule and agenda because there's so many of us now. As providers start to see benefits and things blossom, there's a request to expand in different disease states or expand current services offered. I would just add, this has definitely been my experience, especially from starting out my career, where you really were having to say, I want to work here, I want to do these things, versus now there's a lot more of clinics asking for this type of help or looking into how they can make it work. So I think this was another consensus building type moment.
That was great.
Okay. This is a fun one. Maybe not unique to pharmacy, but you see this big stack of charts here, paper charts, or file folders. The administrative workload can quickly overtake the time for pharmacists to provide clinical care if not carefully balanced. So conveying the clinical benefits of pharmacists and protecting the time from administrative tasks has been a challenge in collaboration. I would say there was a lot of chatter about this as well. A lot of the time spent on prior authorizations, medication access paperwork is not necessarily the best use of clinical skills. The group said that you don't necessarily have to have a PharmD in order to complete those tasks. But there is good insight into how to complete those. So training other people to do those in a more efficient way is a great way to do it. Handling paperwork that no one else wanted to do, and maybe before their schedule was completely filled up, that was a way to do it. Protecting clinical time from administrative tasks has been a challenge. But understanding the value of obtaining those medications from prescription assistance programs and things like that, those less abstract understanding of the pharmacist clinical services, and that those things don't go into the clinical markers. So they don't go into adherence rates and they don't go into those other things, but they do go into the lab values as far as we might could get an A1C down that way. We might could get an LDL down that way. And I do think we heard that pharmacists got pulled into a lot of committees or value-based groups because their viewpoint is different and important. So I think that being the only pharmacist in the clinic came up quite a bit.
Yeah, that was great.
Okay, so this is another funny one. You kind of see someone coming in, and there's a Christmas tree in a dark room. Like, looks like what are you doing here? Are you supposed to be here? Are you breaking in? That type of thing is what this photo kind of evokes. So this is an important topic to bring up here. So one barrier I face is the impression of physician creep, and we have it here in quotes. And so while I feel like I'm walking in, the doors open, lights on, that is not always the feeling with the other collaborators. So sometimes there's a protectiveness over the practice, trying to prevent a home invasion or theft of physician revenue. So this is definitely something that all pharmacists certainly are aware of. And I would say there's varying degrees of awareness with other mid-level providers, physicians, et cetera. So other pharmacists chimed in here and said, I felt skepticism that pharmacists were there to take over the physician's job, especially around tasks that they didn't want to do. There's no physician out there that you're going to hear say, I would really like to be doing this prior authorization. That's really tedious type things. But you do have, most of them had experiences with doctors questioning whether they had certifications to manage certain disease states, and feeling like you had to prove yourself over and over. We had one pharmacist that said they had a physician with arms crossed in meetings, never looked up, but now they are one of their biggest physician champions, willing to drive 1.5 hours each way to explain to others why they need a pharmacist, coming into the office 3 to 4 times a week to ask about questions with new medications and rare diseases. So kind of that continuum of early adopters to those who are your champions or this type of service about what's in the best interest of the patients.
Yeah, and I think one thing I'll add is that all of the pharmacists who participated in the focus group really had stories of how they faced some resistance in the beginning, but were able to turn it around. Like the pharmacist who said the physician champion goes to great lengths to support the expansion of pharmacy into primary care, which was really interesting. So it like takes a foot in the door, I think, sometimes.
I do want to acknowledge on this slide that the American Medical Association did release a statement. It's certainly not the first one, but in February of 2024 on pharmacist scope creep into physician practice. This was all over the internet. If you follow anything online for pharmacists and physicians and other mid-level providers on Twitter, on LinkedIn, etc. So I've got some quotes there for you. So like within the statement, it did say pharmacists are not trained in providing medical care to patients. All of the pharmacists' professional organizations actually joined together to respond, which again, this represents a shift from when I began my career. It would be, I would say, segmented in the response. But now our professional organizations are joining together to respond. And so this statement from ACP, and so that's who accredits our pharmacy schools. And then APHA, which is the American Pharmacist Association, said it's time that the AMA put their needs of the patients above the notion that pharmacists and other healthcare team members are competing with them. Patients want the level of access and are demanding it from our healthcare systems. You can see this. This is from JAFA, an article that was published shortly thereafter. Why can't we be friends? The manufactured fear of pharmacist scope creep. I would say a personal response to reading it was it seemed outdated in response to physicians in real life. Their responses do not seem as hesitant. I do think that it's more maybe a positioning or maybe a lobbying type statement, but with the boots on the ground and with what Corey referred to early in the presentation, with the shortage that we have in the state of Tennessee, and then coupled on the back of that, coming out of the pandemic, where patients were expecting to receive and did receive COVID vaccines, COVID tests, and treatment for COVID at pharmacies across the country. I think the coupling of all of that together is pushing us into a more accepting phase of receiving at least some treatments from pharmacists.
Yeah. And I mean, I'll just say as a bystander, I was shocked to see this. And I agree with you that it probably is outdated. But I'm certain if and we didn't talk to physicians, but I'm certain that if the physicians who work with pharmacists had any ability to weigh in on this, they would not agree.
Okay, so on this one, improving policies and processes. So we have this file folder with policies. So we outline everything in policies and procedures. The process changes that we've made has resulted in positive safety outcomes. Whenever there's anything going in that touches medication, they reach for the pharmacist's input. How should it look? What's the best thing to do? Are we wasting medications? How do we do that? They involve pharmacy in all of those things now. So this is really important because before this, if you don't have a medication expert on board, the other health professions are making the decision, with that, maybe that is a second or tertiary expertise. So this is another really important role that the pharmacist can play in the system. Other pharmacists responded and said, that the credentialing of the pharmacists as mid-level practitioners, they can bill independently. And so that allows the physicians to focus on other aspects of patient care. So I kind of think of this as like everybody on the healthcare team can focus on the things that they are really experts at and they are really good at. And so the pharmacist is not trying to take over anybody else's lane. They're taking over, really working on medications and optimizing those lifestyle conversations and helping to achieve those quality outcomes. Preference lists for things like titration, supply ordering, Epic. So EHR and templates and things like that can be extremely helpful because a lot of the times you'll see the same questions coming up over and over and over again, which leads to those A1Cs or blood pressures and things like that being higher than you want them to be. Medication shortages, these have come up, I mean, at this point, almost a decade. So what do you do when this medication goes on back order or is not available? These are some of the alternatives you could choose from. And that's another place where pharmacists can be invaluable. If pharmacies that, like outpatient pharmacies have questions, the pharmacist in the clinic is a great person to clarify those questions and save time, etc. So that was a lot of that conversation around this.
Yeah, and what I took from this is that, and what I've experienced working with pharmacists is that, I mean, even though their education is in pharmacy, they have the skills to do so many other things and to make huge strides in the practices, and to think, on a level of working across disciplines. And I don't know, they bring a lot to the practice, even beyond working with patients. But as you can see in the policies and procedures that they help set up and the education that they give to everyone in the practice.
Okay, so improving outcomes is a huge area where you'll see pharmacist interventions making a difference. So, and quickly, a lot. So this particular picture is a blood pressure monitor, and then you'll see a CGM, so continuous glucose monitor there. So the pharmacist who was describing this was talking about how certain medications couldn't be taken together. And it can be like a really simple fix in a pharmacist's mind that might not be the first thing in another healthcare professional's mind, or certainly not a patient's mind. And how that can help a patient sleep better at night when they're not waking up, when their Dexcom is alerting them that they have low blood sugar or high blood sugar, because of these interactions that may happen. Being able to see really big drops in A1Cs from being really out of control, like 9, 10, 11, I've had 14 A1Cs, to being more reasonable. And then we're not at risk for some of those really scary complications, heart attack, stroke, amputations, blindness. And patients get so excited about their achievements that they share with the doctor, they share with other people that work in the clinic that they've known and trusted, of how much weight they've lost. They meet up with each other, the people in their diabetes education groups. They start their own walking groups. And that's where you start having that community-based change and community. That's the research that we're trying to do at the Tennessee Heart Health Network. This ties back into the last slide as well. So the picture here is like eating a burrito, and then all kinds of things are falling out of it and kind of making a taco out of it. So falling through a funnel, I guess. So the collaboration allowed me to fill in the missing pieces for care coordination, to close quality measure gaps, disease state education, to understand why behind a provider's prescription, or simply help close the loop on a provider's care plan. Things fall through the cracks, and that just happens. And I help maintain productivity for more complex patients while closing the gaps in care. So what is missing? Is it immunizations? Is it early signs of chronic diseases? Is it that the labs are slightly elevated but not too scary? Is it the blood sugar is 110, but nobody's really explained to them what prediabetes is and how you can prevent diabetes? What about those preventative screenings like the diabetic eye exam, foot exam? There's a lot of things to think about when patients come in. Pharmacists can help make sure that we're doing that not only because it's in the best interest of the patient, but because as clinics and physicians and mid-level providers, we're graded on that, and so is our payments.
Excellent.
Okay, you can see this big bag here of all of these medications. I know we've probably all seen one of these before for a relative, friend, family member. So one of our participants showed us this picture and said we pulled 22 bottles of expired medications out of a patient's home. They were able to implement home visits and disposed of them accordingly. I rarely go to a home visit without coming out with a bag this size or bigger of expired medications, and we don't realize what is actually in our patients' medicine cabinets at home. And probably a lot of us are the same way. If you've got medications, maybe we didn't finish them or don't need them anymore, somebody was allergic to it, what do you do with it? Do I go to the police station when they have that expired medication day? Do I put it in the toilet, or does that go in the wastewater? What do we do with it? There are a lot of things in there that could be tricky. Like what if somebody was cleaning your house and they got a hold of it? What if a pet got a hold of it? What if a child got a hold of it? So this is a great place for pharmacists to intervene and see, should we still be taking it? Maybe sometimes they should be. So in this particular conversation, pharmacists said they've altered their model to joint physician and pharmacist visits. This is another way to justify the pharmacist's salary. You can increase complexity of the visits into one billable visit. We had another pharmacist talk about a patient doing 140 units of 2 different basal insulins, which is that's a lot of liquid underneath the skin for one thing. And if there are 2 different basal insulins, there's no reason for that. This is a recipe for disaster. And so they were able to intervene and fix really unnecessarily complicated regimens like that. The patients are really excited about their achievements.
That's an oopsie.
Yeah, and just talk to the other providers about that. And you can see those changes really quickly too. Blood pressure, blood glucose, and things like that. Do you have anything else on that, Corey?
No.
Okay. All right. So on this one, improving medication safety, you see this like skyline photo and it's blurry. So we had a pharmacist talk about in a new consult for type 2 diabetes, patient was blind in the right eye and had a severe cataract in the left eye and was experiencing a significant number of hypoglycemic events, home alone while his wife was at work. That's very dangerous, particularly as we age, it's more and more dangerous. So the pharmacist was able to spend 30 minutes explaining the pharmacokinetic and pharmacodynamic properties of bolus insulin and the importance of dosing bolus insulin prior to meals. So bolus insulin, for our non-pharmacist friends, is the insulin that your body would typically produce or that you give yourself to cover the meals that you eat and have your blood sugar come back into a normal range. So it reduced his high blood sugar to normal blood sugar. And the hypoglycemic events dropped by 50% by his next visit. So really increasing safety, especially at home, decreasing risk of falls, that kind of thing. Safety is huge. So other pharmacists chimed in and said they've intervened on things like a GI bleed with INR. So that's around medications like Coumadin. Coumadin interacts with even things like food, and it has a narrow therapeutic index, which means sometimes we have to change the dose even within days or within weeks, and it requires really close monitoring. And another pharmacist developed a safety questionnaire that's appropriate and uses that to help manage the patient's symptoms and safety profile to make sure they're on the correct dose. That's a difficult thing to do outside of the profession of pharmacy, like for other professions within the clinic.
And I think one thing I'll add is that the patient that's under the picture that they're talking about, I think that patient was taking the bolus dose after he ate instead of before. So little things like that, that the physician or other people in that practice might not even know is going on, can make a big difference.
Okay. So, this is a picture just like looking out of an airplane window. And you can kind of see like this is a new area, maybe someplace you haven't been. And so underneath this one, the pharmacist said, our multidisciplinary team had a new patient with uncontrolled diabetes and a very high BMI and A1C. So after medication and lifestyle changes, including tailored exercise, she was able to get her A1C below her goal and almost lost 50 pounds. She had not been this weight since the 1970s. And when she lost that weight, she lost it to fit into an airplane seat to travel to Europe with her sister. She was so proud of her progress. So if you can imagine that amount of time since the last time you felt healthy, you know, that patient describing that amount of change she was able to do in a short amount of time with her healthcare team. Not only does that feel really good to the patient, but it also feels good to the healthcare team to be able to assist in that change. Some of the other pharmacists' comments were, I have 6 siblings, some are dead and some are living, but everyone is without a limb, and this is going to happen to me. So the clinician then kind of stopped and talked to him about acceptance, and when that pharmacist saw them 3 months later, he was an evangelist for diabetes, and his blood sugar and A1C were under control. Another patient lost 12 pounds over the holidays, and she said her husband had left her, and she hadn't told a single person, but wasn't able to eat. So she lost everything except her beloved dog, and she spent the next few months talking about her dog. And this gave her the support to tell others. So, really what we're talking about there is the ability to build relationships in primary care and why it is important to take some of that time that we're not able to have in a typical 15-minute E&M visit that goes into something that's beyond an ICD-10 code, a problem list, and how to fix it. Do you have anything else on that one, Corey?
No, you did a great job.
Okay. And with that, we've got a couple of questions here in the chat. What led to your decision to use photovoice? I'll let you answer that one, Corey.
I love photovoice because it does incorporate the pictures, which I agree with the adage that a picture's worth 1,000 words. And I think it helps convey the messages and the experiences that the participants in the study have experienced in a way that you can't really do just through identifying themes in qualitative research.
Are there any plans to have physicians respond to the results? And what are your next steps to improve outcomes and quality measures?
That's a great question. Part of the reason we did this study is to make this available, well, to publish the work and in a journal that is hopefully targeted to primary care physicians, so that hopefully we can reach some primary care practices that maybe don't know about this intervention or have been on the fence, and this may give them the push that they need to maybe look into this a little bit more and implement this in their practices. Also, I think we'll make the information available through our newsletter that goes out to the primary care providers across Tennessee. But basically, I think some of the next steps are just getting the word out, and encouraging. I think Dr. Ellis said she's working on making the resources that were developed available to others across the country. And maybe we can use some of the findings from this research to help get that message across. I don't know. What do you think?
Yeah, I would love to hear your thoughts on it. One of the things that we are actively trying to do as far as where our target journal is to publish not in a pharmacy journal, because the results of this are, consensus among the pharmacists. As a pharmacist, I would say this is what we already know. So we want to share it with pharmacists. We want to share it with the broader provider community and payer community as well, so that there is fair payment for the services and sustainability. And those are some of the primary challenges to implementing the work on a larger scale.
But yeah, and we did talk some about encouraging people who are in pharmacy school right now to become more interested in this clinical pharmacy as a career. So there might also be some opportunity to present this work to some of the students in some of the pharmacy programs. That's a great question.
Any other questions? Thank you so much.
Yeah, thank you so much for participating.
Oh, I see.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.